Hi everyone, this is Seher again from Dentabest.com, and today we are going to do the review on operative. So let us start from the table of contents first. So in the table of contents, we have the dental caries, the clinical examination, treatment planning, hand instrumentation, power cutting instruments, tooth preparation, moisture control, liner bases and cements, properties of restorative material, amalgam restoration, dental bonding, inlays, onlays, and the fluoride section. So we can see the dental caries, and this is called as a Venn diagram, in which we can see there are three factors that mainly lead to dental caries, in which we have the tooth, which is the host, the flora, the bacteria, in which Streptococcus mutans, as we know, is the initiator bacteria of the caries, and the substrate are the carbohydrates. Now, the saliva, as we know, it has a buffering capacity by the bicarbonate ion that keeps pH close to neutral. But the Streptococcus mutans bacteria that is starting the caries, it has the glucosyl transferase enzyme that is going to convert the dietary sugar or sucrose into glucans and fructans, where glucans are the polymer of glucose and fructans are the polymer of fructose. Fructans are also called as levans, glucans are also called as dextrans. Now, as a byproduct of this reaction, lactic acid is produced that is going to reduce your salivary pH, and once the pH hits 5.5, below that is called as critical pH. That's when the demineralization of the enamel is going to start and you're going to have the caries. Now, this is called as a specific plaque hypothesis that states that not all the plaque is pathogenic, is cariogenic. Some of the plaque produce caries like Streptococcus mutans bacteria, and Streptococcus viridans, for example, doesn't cause caries, less virulent, it mainly produces the plaque. Okay, so here we can see the zone of dentinal caries, but we should know that lactobacillus is a bacteria that helps in further progression of the caries. It's also involved in deep caries, and we can see the zone of carious dentine is divided into affected dentine and the infected dentine. So affected dentine is like zone 2 and 3, where demineralization has happened, but bacteria are still not present, while in zone 4 and 5, you have the infected dentine, where the bacteria are present. So zone 4 and 5 need to be removed. So zone 2 and 3 will become normal again, or they can remineralize again. Now we know there are three types of dentine: primary, secondary, and tertiary. Tertiary dentine is formed by secondary odontoblasts, also called as reparative dentine, in response to atresion, trauma, or the cavity preparation. So caries in dentine will progress very fast along the direction of dentinal tubules, but until the time caries are in enamel, because enamel is highly mineralized, the progression is going to be very slow. The dentinal caries are going to progress along the direction of dentinal tubule, and the enamel caries are going to progress along the direction of enamel rod. Okay, now let us see how we can examine the caries, like by visual changes on the tooth surface, brownish discoloration, tactile sensation or catch in your explorer, use of radiographs, transillumination, diagnodon, diphote, QLF, electronic caries. So none of this method is complete in itself. It has to be combination of different methods for proper examination of the caries. Now, the caries indicating solution can be used to distinguish between infected and affected dentine, so that you know, okay, this is an infected dentine, we need to remove it, so that affected dentine can become normal again. The proximal smooth surface caries, as we know, the most accurate method for the interiors is transillumination, and most commonly is wedging the tooth and taking the x-ray by tooth separation, while for posteriors, bite wings are considered to be the most accurate. So proximal surface caries, they start wide at the surface and converge to the DEJ, and they are usually located gingival to the interproximal contact. They progress slower than the pit and fissure caries. So as we know, caries are most prevalent in the faulty pit and fissure, and pit and fissure become faulty or deep where the lobes don't fuse or coalesce properly. So pit and fissure caries are narrow at the enamel surface and spread wide at the DJ. They give an inverted V appearance. And how much you can see caries on the clinically, they're actually much more larger than what they are seen clinically. Pit and fissure caries is mainly caused by Streptococcus sanguinis, and we know that if the caries are just into the enamel and they are less than 1/4 defect in the enamel, you don't have to make a cavity. You can just do fissurotomy or smoothen up the pit and fissure. Cusp tip caries are GV Black class 6. We'll discuss about GV Black classification in the coming pages, and they're just result of developmental enamel defects. They are least common caries we have. And you can see the angles of the burr blade here, like the rake angle, edge angle, clearance angle. Rake angle is an important property. Negative the rake angle, it is used more for harder cutting, like cutting of amalgam, tooth. Positive rake angle is for softer cutting. While clearance angle is between the clearance face and tangent to the path of rotation. Now the round burrs, as we know, they are used for punch cut or initial entry into the tooth. And these round burrs like number 2, number 3, small carbide round burrs, they can also be used for preparing the retentive features like retentive grooves or coves, and the caries removal like slow speed revolving round burr for pulpotomy. Inverted cone burr. So burr numbers are also important. Sometimes they are asked in the exam like burr number 34, 330, 56, 169, and mainly the functions of them. What is the purpose? Okay, so we can see the initial tooth preparation stage, which has the outline form, resistance, retention, and the convenience form. And you can see that how the outline form is being prepared, extending a weak wall, eliminating a weak wall. You do extension for prevention, especially in amalgam, and use enameloplasty when the fissures are narrow, they are being shallow. Initial depth of the preparation is 0.5 mm into the dentine or 1.5 mm total depth as measured from the central groove. Flat pulpal floors to the occlusal surface, occlusally divergent proximal wall, rounding of axiopulpal line angle, and smooth surface preparation. Never end on the cusp height and extend margin flow to get the clearance. That's important in the embrasure or the self-cleansing areas. You can see more features of the resistance form here that we already discussed about it. Only defective pit and fissure are included and all the margins are on the sound tooth structure. The rule for the cusp capping is if the extension is from primary groove towards the cusp tip, no more than half the distance, no cusp capping is needed. The extension is half to 2/3, consider cusp capping. But the extension is more than 2/3, definitely you need to cusp the cap. So these are the rule of cusp capping. This is a very good comparative table between the silver and the cast restorations. You can see here where intercuspal distance is 1/3, outline form is wide, but here outline form is narrow for the amalgam. Intercuspal distance is 1/4. Buccal and lingual wall are parallel. Here they are converging. Butt fit joint, but for your casting, it is all cavo surface bevel is given. Cavity walls are parallel here. They are converging here. Then you can see the depth of the preparation, which is less in casting as compared to silver. Rounding line angle, point angle. While in case of casting, you can see they are sharp. Only axiopulpal line angle is being rounded. Reverse bevel is given in the case of casting. And grooves are given in facio-axial and linguo-incisal line angle. While in this case, we can only give the locks for the proximal class 2 preparation. Restoration. With inlay-onlay, the use of base, shallow to moderately deep excavation. If at least 0.5 mm dent is remaining, nothing is needed, no liner, no base. But deep excavation again, 0.5 mm within the pulp. All the restoration will require a calcium hydroxide liner first, so that it can make some reparative dentine, and then you can give the restoration because they are luting, they are cemented inlay-onlay casting, so you don't need any base here. Now GIC, as we know, let us read something about the cements here. So GIC is fluoroaluminosilicate glass powder, liquid or polyacrylic acid. Having fluoride, it has an anti-kerugenic property. And glass ionomer, it bonds chemically to the tooth structure. We have the self-cure as well as light cure form. Although they are tooth colored, but they do not polish as well as composite. They're used mainly in the class 5 where there's low stress bearing area, low solubility. It doesn't have as good strength as your amalgam or composite. Mainly for class 5 we can use it. Now Zoe, as we know, it's a sedative cement because of eugenol or clove oil in it. You cannot use Zoe under composite because eugenol can interfere with the polymerization. Zoe is used in indirect pulp capping where still there is a layer of dentine over the pulp, but you cannot put Zoe directly over the pulp because the clove oil or eugenol can be irritating. Zoe definitely is a very neutral cement, least irritating among all if it is not in contact with the pulp, and it is used as an interim restoration or a temporary restorative material. Now we talk about the bonding topic. There are different advantages of bonding, but if they ask you what's the most important advantage, your answer is to reduce the micro leakage. There are different uses of adhesive technique that also you can go through it. What's the difference between enamel and dentine bonding? Enamel bonding definitely is more reliable, predictable, less micro leakage, resist polymerization shrinkage better than the dentine bonding. So we have different system here. SEP system, that's the most popular system. Self-etching primer bonding system, where etch and primer adhesive all are combined, or etch and primer are combined and the adhesive is separate. The good thing about SEP system, it doesn't remove the smear layer completely, so chances of post-op sensitivity are lower than the other systems. The advantage and disadvantage of the SEP system, definitely less sensitivity is there, but disadvantage is that bond strength is lower. Bond strength of auto-curing composite is poor and clinical performance is not yet proven. Now we can see here the unfilled composite, they are softest of all restorative material. The chance of percolation is higher in them. They have less wear resistance. So more is the filler, better will be the physical properties. Now the microfill composite, they have very small glass filler in them. So physical properties are definitely lower as compared to conventional composite, but having smaller size of filler particle, they are very smooth and have good wear resistance at the same time. Now we can see here the composite is made up of three phases: the resin phase, the filler particle, and the coupling agent. Resin matrix is made up of BIS-GMA or UDMA. You can add Tegma to it, like in Pitt-and-Fischer sealant, to decrease its viscosity and make it more flowable. Then you have the coupling agent like silane. Now the initiator in the self-cure composite is benzoyl peroxide, while in light cure it is diketone or camphoraquinone molecule. The accelerator or activator, we have the tertiary amine, and also adding the pigments. So mostly we use the light cure composite where it is cured by the blue light, LED light with 470 nanometer wavelength, and hold the light as close to the resin as possible within 2 mm. And for resin, you always do incremental curing in layers so that the chances of polymerization shrinkage are being reduced. Hi, my dear student who are preparing for IMD ADAT or Part 2 exam. Thanks so much for watching this review video of the subject. If you really liked it, please buy the full version by clicking on the link given in the description. With the purchase of every video, you will be getting free live assessment and evaluations on the subject as well. Also, don't forget to subscribe to the Dentabest channel now to get the latest updates on the smart videos. If you have any questions, please comment me in the box below. I, Dr. Seher from Dentabest, wishes you all the best for exam, and thanks again for watching.